Hi everybody and welcome to our today's class. My name is Raphael. I'm an expert on psychopharmacology. In this class, I'll be talking about one of perhaps the most important class of medications called selective serotonin reuptake inhibitors, popularly known as SSRIs. SSRIs. SSRIs, selective serotonin reuptake inhibitors, are indicated. The indication for this medication is depression. So indication, depression. Now, apart from depression, SSRIs can also be used in treatment of other disorders. For example, anxiety disorder, panic disorder, phobia, OCD, PTSD, and bulimia. So, apart from just treating depression, there is evidence that these medications have also been helpful in treating these disorders: anxiety, panic, phobia, OCD, PTSD, and bulimia nervosa. Now, these selective serotonin reuptake inhibitors, this is important. They are first-line medications for depression. So we're saying they are first-line. So if your patient has depression, we go for this SSRI first. We're not saying that we just stick on them alone. We have other classes of antidepressants, but we are saying this is first line. And of course, you will choose a medication for your patient based on the presenting signs and symptoms and based on the profile of the medication. So I'll quickly take you through examples of selective serotonin uptake inhibitors and quickly go through the profiles of each and why you should choose one over the other. So let's look at examples of the SSRIs, which are the first line medications for the treatment of depression and these other disorders. So examples. Here are examples of SSRIs. We have one, fluoxetine. Two, we have paroxetine. Three, we have citalopram. Four, we have citalopram. 5, we have sertraline. 6, we have fluvoxamine. Now, for those preparing for the board exams, you will realize that the board presents this medication both in their generic names and in their brand names. So these are the generic names for this medication. There are these 6 selective serotonin uptake inhibitors, which are first-line medications for treatment of depression and these other disorders. But there's no harm for knowing the brand names. Most of these older physicians will prescribe these medications using the brand names. So it doesn't harm knowing the brand names. So the brand name for each of these medications here, fluoxetine is Prozac, paroxetine is Paxil, escitalopram is Lexapro. This one is Lexa. Sertraline is Zoloft. Fluvoxamine is Luvox. So I'll take you through each one of these medications and why you should choose one over the other, and some of the reasons why you should not choose some. So let's start with fluoxetine. So fluoxetine also called Prozac. Now, these are some of the facts about fluoxetine. Fluoxetine, of all the SSRIs, fluoxetine is the most energizing. So this is the most energizing. Energizing or the most stimulating. So we are saying that of all the SSRIs, fluoxetine is the most energizing. And what is the effect of most energizing medications? So if a medication is energizing, it gives a patient energy, motivation to do things. So don't give this medication to a patient at night. Do not give at bedtime because the patient will not sleep. We are saying that some medications here are energizing too. Sertraline is energizing, but it's not as energizing as fluoxetine. You know that a patient with depression may present with signs of lack of energy, right? Among many other symptoms. So if your patient is saying he doesn't have energy, then you want to give fluoxetine. If he's depressed and he lacks energy, then I'll go for fluoxetine. Now, another fact about fluoxetine is that of all the SSRIs, fluoxetine has the longest half-life. So, longest half-life. So, if it has a long half-life, then it means it has less rebound. Less rebound effects, very important. Long half-life, less rebound effect. I'm talking about the withdrawal symptoms. So such medication, fluoxetine, self-tappers. Okay. Now the downside of the long half-life is that if you are adding another serotonergic medication, you realize that some patients may need a combo of 2 or 3 antidepressants for them to feel better. So you may give a patient one serotonergic medication and he's not improving. then you'd want to add another serotonergic medication. So in this case, if you are adding another serotonergic medication to a patient who is already on fluoxamine or fluoxetine, you need to be careful, because this medication, since it has a longer half-life, it will be lingering in the system for a longer period of time. So if you add another serotonergic medication, then you are increasing the risk of this patient getting serotonin syndrome. You don't want your patient to have serotonin syndrome. We will look at serotonin syndrome later. So that's one of the downside of a longer half-life. Now let's look at paroxetine. Paroxetine, Paxil. Paxil, the opposite of fluoxetine. Fluoxetine is the most energizing, the most stimulating. Paroxetine is the most sedating. So this one is the most sedating. And don't get me wrong. I'm saying the most sedating of all the SSRIs. We have other antidepressants that are more sedating than this. We have antipsychotics that are more sedating than this. We have narcotics that are more sedating than this. So don't say I said this is the most sedating. I said it's the most sedating of SSRIs. So of SSRIs. Apart from being more sedating, they have the shortest half-life. So back to more sedating. A medication that is more sedating, you don't want to give it during the day because you'll have ruined the patient's day. Give it at bedtime. Please give paroxetine at bedtime because it's very, very sedating. Now, we are saying that it has the shortest half-life. Hey, a medication with a short half-life will have very bad rebound effects. So the rebound effects will come up very quickly, the withdrawal symptoms. So if you want to taper, be very careful. If you want to discontinue, be very careful. Actually, the half-life of paroxetine is less than 24 hours. It's less than 24 hours. Now, paroxetine, literature has shown that it has birth defects. It has birth defects. So, since paroxetine has birth defects, pregnant patients no. So, no. So please, as a provider, do not prescribe paroxetine to your patient who is pregnant, because there's literature out there, there's data to prove that paroxetine can cause birth defects. So another class of another SSRI, we have escitalopram and citalopram, Lexapro, and Celexa. These medications are basically the same. However, 10 milligrams of Lexapro is the same as 20 milligrams of Celexa. Well, they're pretty good medication with no non-adverse effects. However, there's one very important thing you need to know about Celexa and Lexapro. Very, very important. Very, very important. This is a high yield area for those preparing for the board exams. When you're giving Lexapro or Celexa, remember that it causes prolongation of QTC, or simply say it causes QTC prolongation. QTC So, what is the consequence? What is the consequence of a prolonged QTC? A prolonged QTC is very, very dangerous because it can cause what we call arrhythmias and sudden death. Yep, it can cause arrhythmias and sudden death. Therefore, it's important, very important, utmost important, critically important that you monitor your patient's EKG. So, monitor EKG. Monitor EKG of your patients when you're giving this medication. Monitor EKG. Make sure this does not happen. Better still, I would rather not give this medication to patients with pre-existing arrhythmias. Pre-existing arrhythmias or cardiac issues or cardiac problems, don't give. So be safe. You know, what's important is that your patient is safe. And that's what the board is looking for. Are patients safe with their prescription? So if you're giving Lexapro, if you're giving Celexa, you need to monitor your patient's EKG or ECG so that you'll be able to catch this QTC elongation and avoid arrhythmias and sudden death. So another medication that we look at under this SSRI is sertraline. Also called Zoloft. Now, this is the most popular of the SSRIs, the most popular. It's not the most sedating, it's not the most energizing, but it's the most popular. Why? Because it has less side effects. Apart from GI upset, we do not know any other side effects of this medication. It causes GI upset, that's it. Other than that, it's the safest safest in breastfeeding and pregnant patients. So the downside is it causes GI upset. So GI upset is nausea, vomiting, and diarrhea. So that's why it's popular. It's popular. So in my practice, I go for Zoloft first. And Zoloft, just like fluoxetine, is sedating, but not as much sedating as fluoxetine. And then we have this other medication called fluvoxamine, Luvox. This is basically, I usually say this is messy. It's messy because it has a lot of adverse reaction and interaction with other medications. So we rarely use it in practice. So mostly you'll be using sertraline, you'll be using Lexapro, Lexa, paroxetine, fluoxetine. But as I said, you pick on a medication based on consider the signs and symptoms your patient is presenting with, keeping in mind that not all depressed patient will present with the same signs and symptoms, but we have, those golden signs and symptoms that most of them will show up with. And secondly, you also choose the medication depending on their profile. And if you've chosen an SSRI and then your patient is not improving, you can add another class of antidepressant, let's say serotonin or epinephrine reuptake inhibitor, or you can add a TCA, or you can add a typical antidepressant. We'll come to that later. But right now, I'm saying that the first line medication for depression is the SSRI. Okay, and you can, if your patient is not responding to any of these ones, you can combine with another antidepressant from another class. But as we said, you need to start low. You don't start combining before you've tried the first one. So I'll start with sertraline, for example, depending on what the patient is presenting with, and then if the patient does not improve, I can switch to another SSRI, or I can combine with another class of antidepressant, or I can go for the second line altogether and forget about the first line. Okay. Now, let's look at the side effects of selective serotonin uptake inhibitors. So, as a provider, when you are prescribing this medication, you should be able to educate your patient, of the expected side effects and those ones that they need to report to you, because some of them, if they are adverse, it's affecting their way of life, or it's a medical emergency, they need to report quickly. And some are the common side effects that they need to be aware of when they're taking some of this medication. So I'll give you a mnemonic of these side effects. I'll give you a mnemonic. So side effects of SSRIs. I'll give you a mnemonic called SPARROW. Don't forget that. High yield. S, sleep and energy. Sleep and energy. Now, SSRIs cause sleep. Some give you energy. Remember, when we are looking at paroxetine, we said paroxetine is sedating. Sedation makes you sleep. Remember, fluoxetine, we said, is the most energizing. Gives you energy, stimulating. Remember, when a patient has depression, they present with a wide range of symptoms. Some of them may have insomnia. Some of them may lack energy. Some of them may lack appetite. Some of them may lack interest in doing activities that they've been doing for years. Okay? So, Sleep and energy. Sleep and energy. Don't forget that. Then we have P, platelet. So when you're talking about platelet dysfunction, what comes into your mind? Bleeding, right? So SSRIs can cause bleeding because they cause platelet dysfunction. Well, this is not very common unless the patient is taking anticoagulants like warfarin, warfarin is also called Coumadin, or they are on heparin, or they are on Zoroto, or they are on Lovenox. That increase their chance of bleeding. Okay. Then we have abdominal. Upset. This is nausea, vomiting, and diarrhea. So SSRIs can cause abdominal upset like nausea, vomiting, and diarrhea. Then we have reproductive function. This is high yield area, reproductive dysfunction. Now, selective serotonin uptake inhibitor can cause sexual dysfunction. In fact, one of the reasons most patients taking antidepressants become non-compliant is because of this sexual dysfunction. The patient will lack a sexual arousal and will lack the ability to even maintain it, and they may not even experience orgasm. So it's important that you educate your patient about these side effects. And that's why you need to ask them if they're sexually active, although some patients may shy away and refuse to respond to such questions. But you can tell from their age, not that there's an age limit when people can have sexual activity, but it's important that you ask them if they are sexually active, because these medications will affect their sexual life and potentially their marriage. So then we have O for overdose, causing serotonin syndrome. This big as a provider. When you're giving medication, the SSRI, in your mind, what can potentially go wrong? An overdose of selective serotonin uptake inhibitor, the SSRI, causes serotonin syndrome. We'll look at serotonin syndrome next. That's a high yield area. Don't walk into an exam room if you do not know what serotonin syndrome is. If you do not know the signs and symptoms of serotonin syndrome is. If you do not know what causes serotonin syndrome. If you do not know the difference between serotonin syndrome and neuroleptic malignant syndrome, we'll look at that too. So, and then we have W to mean weight gain. So, most psychotropic medications cause increase in weight because of the changes of because of the metabolic changes. So weight gain is one of the side effects of antidepressants. Now we've talked about serotonin syndrome, and as I said, this is a big area when you're giving serotonergic medication. So let's look at the signs and symptoms of serotonin syndrome. And again, I have a mnemonic that will help you to remember this. So serotonin syndrome. This mnemonic is a bit funny, but I'm gonna use it. So I'll use shits and shivers. Now, shits here to mean diarrhea. S here, shivering. Hyperreflexia. Now, these three are the hallmark of serotonin syndrome. They are the hallmark of serotonin syndrome. Diarrhea, shivering, and hyperreflexia. Now, these others here, we have V for vital sign, instability, encephalopathy, restlessness, and sweating. Now, vital signs instability may include things like tachycardia, things like tachypnea, things like hypoxia, things like hypotension. Okay? So, vital signs instability. Then we have encephalopathy. If a patient has encephalopathy, what does encephalopathy cause? Altered mental status. So encephalopathy causes altered mental status. Patient may act cuckoo. Then restlessness, then sweating. Now, these three are hallmarks: diarrhea, shivering, and hyperreflexia. Now, most students will confuse serotonin syndrome and neuroleptic malignant syndrome. So do not confuse neuroleptic this is not serotonin syndrome. These, the hallmark signs and symptom of neuroleptic malignant syndrome is high temperature, and rigidity. Different from the hallmarks here. Another difference is that this is caused by antipsychotic medications. This is caused by selective serotonin reuptake inhibitors, SSRI, which is antidepressant. Very different. Ladies and gentlemen, thank you for watching this video. In our next class, I'll be looking at another class of antidepressant called serotonin norepinephrine. the uptake inhibitors. And for those of you out there preparing for the board exams, especially the psych, mental health nurse practitioner exam, I'll be your great source. And you're going to pass this exam on your first trial. Thank you again, and keep watching. Thank you.